Good day, ladies and gentlemen. Today's topic is of perpetual interest, and therefore, as usual, we'll start with a prayer. This topic, recurrent pregnancy loss, Vadis, is the re-recording of a talk which I have just recently given at AICOG in Calcutta. It was a keynote address, and it generated lots of interest, and therefore I found it fit to get it re-recorded. Why must the organizers have selected me? Maybe these contributions of mine might have encouraged them to invite me to cover this topic. It is quite interesting. Quo vadis, where are we and where are we going? Regularly during our clinical practice or any scientific pursuit, we keep reviewing the situation, and this is a part of that. Patience is also a form of action. Patiently taking history, our teachers used to teach us that 80% of times will give you the diagnosis. And therefore, I become very patient in taking histories in subjects of recurrent pregnancy loss. I take a very detailed history and review the papers also very, very patiently. Yes, it allows me to reach diagnosis of the cause in nearly 80% of subjects, after which lab investigations become very focused. Now, what are the pillars on which I rely on? Whether the loss was early, that means up to 8 weeks pregnancy, or late losses. If it is the early losses, then most likely to be chromosomal or endocrine. If it is a late loss, very likely to be anatomical or immunological. Now, how to differentiate the two? If it was an early loss, was there any feature of endocrinal challenge? If no, then it is most likely to be genetic. If it is a late loss, then whether FHS were detected and lost? Yes, then this was immunological. And if FHS detected till the end, means even sometimes the mother will tell that the abortus or the abortuses were live till the end. Now digging deep inside, exercising the gray cells still more. I also go sometimes on the family history, not sometimes, just a passing question. Was there any family history? And if there is a family history, then it can give you lead to protein S deficiency and factor V laden deficiency. Please take a note. Both are very rare. You may find hardly once or twice in 2-3 years. Let us see the factors individually. Genetic factors. Where are we? Where are we going? Now, where are we? Pre-implantation genetic diagnosis is being forwarded everywhere, in every lecture which I see, as a treatment option for translocation of carriers. Now, for you and me, we should understand that this is a diagnosis option. And second, since this technique will require that the couple undergo IVF, the couples with proven fertility, though having recurrent pregnancy loss, should be aware of the fact, and we should make them aware that their implantation rates in this technique will be lower than your spontaneous conception. So please don't be disheartened. Success rate in pregnancy itself can go down. The finding of the abnormal parental karyotype should promote a prompt referral to a clinical geneticist. We all do this. And I'm not going to give you a talk as a geneticist, but concentrating on as a generalist on Vadis. If karyotype of the missed pregnancy is abnormal or the missed conceptus is abnormal, then there is a better prognosis in the next pregnancy. Please understand this. What does that mean? If the subject has recurrent pregnancy loss and products of conception showed a loss was due to, say, the chromosomal anomaly in the products of conception, then this rate will be lower than a sporadic pregnancy loss, and this will go on increasing the difference, and the number of cases with POC being genetically abnormal will go on decreasing more and more as number of pregnancies will advance. This will reassure the subject and will also make you alert not to start jumping in each and every abnormal report. Where was the abnormality? Now we come to an area which is slowly but surely coming in our practice. That is where we are going. I have already started getting phone calls from people all over the country as to whether they should undergo or they should make their patients undergo an NGS. Now, what is an NGS? NGS is a new generation sequencing. This is something new which has come. And as of now, my answer to them is that it is not recommended for recurrent pregnancy loss because there is high cost and high variance of unknown significance. So you may mix up an abnormality with a normalcy. Therefore, as of now, please wait, this technology is settling. Just because, but some of us have this type of attitude that something new comes, we immediately try to latch on. Please wait. This technology has still not settled. Thank you, Dr. Joel Banker, for providing with this very important input. And it is important to know that the test which you are going in for, so that a thorough counseling of the couple can be done. This applies to the practitioners. You must know which test they are likely to undergo. And we know about, as of now, karyotype, array, these are done. NGS regarding RPL, please wait. Now, what is happening in the field of anatomical factors? Endoscopic workup, both laparoscopy and hysteroscopy for recurrent pregnancy loss, especially in anatomical causes to rule out or commit some abnormality, structural abnormality, may be acquired or this genetic or congenital, is now not done. A good three-dimensional ultrasound will offer you both diagnosis and classification of uterine malformation. So people have now switched over to this. Also, many times we try to diagnose this because we were taught this in our MD exams or we read it in our MD exams, that there are tests available in non-pregnant states to identify, like passing of the Hagar's dilator number 8 without difficulty in a given subject who is non-pregnant. If that is done, normally they should not be able to pass even the thin dilator without any difficulty. There will be some resistance. And this was touted as the test in non-pregnant state. Latest evidence shows that there is currently no satisfactory objective test, and therefore, please, examiners, stop asking this question, and practitioners, stop doing this test. I read an interesting comment regarding handling of short cervix in subjects of recurrent pregnancy loss at 14 weeks. The comment said that more than 3.5 centimeters, if you find, do nothing. If it is 3 to 3.5 centimeters, give progesterone. And if it is less than 3 centimeters, you review clinically and do cerclage. Well, cerclage is an invasive procedure. And nowadays, people are very actively considering progesterone be given more role. And some of practitioners have already started giving role. I am going to go that in a little detail. But what I want to stress here is that a vaginal ultrasound or an ultrasound itself will give you a very good idea as to how, a reliable idea rather, as to whether any intervention is required on the basis of the length of the cervix at 14 weeks. We now come to a very rewarding area. And what is that rewarding area? That rewarding area is progesterone. Endocrine causes, where are we and where are we going? And this is where we are as regards hormone therapy is concerned. Now the picture is very clear. See here, they supplemented progesterones in recurrent pregnancy loss, and Cochrane database 2019 shows that even for unexplained recurrent miscarriages, supplementation with progesterone helps. In general, it helps. Now, for you as a practitioner, the question will be which route? We know there are three routes: oral, vaginal, and intramuscular. We know this. Advantages, disadvantages also we know. Which route we should use? Well, I don't get confused. I have a good news for you. The route is, it doesn't matter. If the progesterone by any way should go in, paths may be different, the destination and the results are the same. Next, which quizzes practitioners? So many progesterones. And sometimes the pharma people straightway with impunity claim that their progesterone is better than others. Now look at these two papers. 2020 paper says that vaginal micronized progesterone helped. A 2018 paper says that medroxyprogesterone acetate and dydrogesterone both helped. So what is the answer? The good news is that which progesterone doesn't matter. Progesterone should go in. So when there is a confusing picture like this, we turn to our peers. And we have some excellent recommendations coming from Foxy, our alma mater, our mother institution, our non-biological mother, which always guides us. And their good clinical practice has shown that if you are giving an oral route, then dydrogesterone 10 milligrams twice a day till 20 weeks. And if you are giving a vaginal route, then micronized progesterone 400 milligrams per day vaginally. Some people are giving up to 36 weeks, but that there are specific indications, and it is beyond the scope of this lecture. Somewhere now conscience steps in, whether we should give HCG or not, because the picture is still a little fuzzy. There is insufficient evidence to evaluate the effect itself. And therefore, what the message of this lecture is, continue your policy, whatever you are doing. Anywhere PCOS has become a matter of grave concern, most of the times unwarranted, and even in recurrent pregnancy loss. PCOS morphology itself does not predict an increased risk of future pregnancy loss. Therefore, please don't start jumping. Also, hyperprolactinemia, in absence of clinical evidence, is not responsible for recurrent pregnancy loss. What about the two very, very fashionable and in vogue endocrinal disturbances? Let me give you a clear message. Routine screening for occult diabetes and thyroid disease with oral glucose tolerance and thyroid function test in asymptomatic women presenting with recurrent miscarriage, asymptomatic as regards these conditions are concerned, is uninformative, should not be done. I am giving clear messages so that you can apply them in clinical practice straightway from the next patient itself. These days, the main focus of recurrent pregnancy loss is on immunological diseases. It is not because they are complex, but because we have not been able to do much in the treatment of cause. And it is quite understandable, because this is a very new condition. Why I am telling this? You imagine the earth to be 24 hours old, suppose. Then in that case, apes are on this earth for last 15 minutes only. Humans are on this earth for 1.8 minutes. Now, the autoimmune conditions in them are still younger. Therefore, we have not been able to unravel all these mysteries. It probably evolutionary obstetrics can have an answer to it. But as of now, we are treating the effects and therefore can fail and fail more than once. Don't be disheartened because the cause is still intact. In 2013, a novel clinical criteria came which cleared thrombotic APS, TAPS from APS, antiphospholipid antibody syndrome associated with our conditions, obstetric morbidities. And that was good because there were many questions asked about this to us. APS is present in one clinical condition, I'm enlisting them soon, and one laboratory criteria, then this is obstetric APS. Recurrent missed abortions, preeclampsia of early onset, recurrent stillbirths, IUGR of placental origin, or accidental hemorrhage. And in laboratory criteria, persisting circulating antiphospholipid antibodies with these sub-criteria. Then and there at least one of the two, then and there only please call it APL. In clinical practice, this is what I am asked many times. Should we repeat it? In clinical practice, if the GPL units are more than 40, there is no need to repeat. Repeating is usually if it is less than 40 and something has made it false positive. Theoretical recommendation is for repeat after 6 to 12 weeks. However, the biggest villain here is viral infections which can cause test it false positive. But they will never go beyond 40 and therefore if it is beyond 40, don't repeat. Where are you going? This we were knowing. Now in autoimmune causes, where are we going? Remember, pregnancies associated with APL treated with aspirin and heparin still remain at a high risk of complication during all trimesters because we have treated the effect and not the cause. But our concentration today is on early stopping of heparin. Can we? Indication for heparin is confined only to immunological losses, both autoimmune and alloimmune. All cases don't start heparin. Once you start daily injections, sometimes costly injections, whichever heparin you give, correctly indicated, it will act. But if you want to stop it early, then your color Doppler at 14 weeks of uterine artery will help. If you find, these are all our published data, those subjects who show PI less than 1 and absent diastolic notch in both uterine arteries at 11 to 14 weeks will be a very small number. But these are the cases where the obstetric vasculopathy has been taken care of, the immunological challenge has been attenuated. In these cases, very few cases you can stop, and we are stopping without any problems. Can you stop heparin? Is there any criteria at second trimester? You found some high-risk features, which I have discussed in many of my lectures. You will find in this YouTube channel also. You identify them as high risk. Now you want to use it as a, even can we stop it in low risk? We just started it. Maybe even in primaries. Can you stop? Yes. If you find that PI in both the uterine arteries is less than 1 and diastolic notch is absent in both, then this is even in second trimester. That means the vasculopathy has taken care of. You can stop heparin. I repeat, which heparin doesn't matter. Cost, if it matters to the subject, then your unfractionated heparin will be costing around 7,000 to 8,000, and the low molecular weight heparin, which is very fashionable, will cost around 40,000 to 45,000. Reports are conflicting, not enough reports or data regarding its use in pregnancy, in prevention of recurrent pregnancy loss. Therefore, both are effective. Matter of concern for us today is the abuse and misuse of heparin. And one abuse and misuse, I told you, using in all subjects of recurrent pregnancy loss. No. Only in immunological causes it will act. And second, let me tell you, I have seen it being used or prescribed in ART pregnancy with no past losses. Sorry, no, this was not indicated. It surely immunological cause indicated, use it. Subject with only one miscarriage, not effective, don't use it. Subject has immunological losses, fails to respond only to aspirin like last pregnancy. These are the cases. Or even once there is a major obstetric vasculopathic disaster, you can start heparin. And this you will be able to reduce your use of heparin by 16 times. This is our data. We are now using heparin compared to past only 6% of times. So stop misusing heparin. There is one thing which goes on repeatedly appearing, and that is immunotherapy. Something latest has come for this. Paternal cell immunization third-party donor in 2014 was found to be no significant benefit. But 2022, there is a study which has come which shows that lymphocyte immune therapy demonstrates some benefit in improving pregnancy outcome of patients with RPL only from alloimmunity, not all immunity. What about intravenous immunoglobulins? Not intramuscular, doesn't help. Intravenous immunoglobulin is increasingly used, once again 2022, as a treatment. Recent data in IVIG might be more effective in a small subgroup of women with an aberrant immunological profile. We saw quite a few aberrant immunological profiles during corona days. If there is such an aberrant profile, then yes, there this can help. Some new solutions are coming up on the horizons. Hydroxychloroquine, statins, still I am afraid on for its use in pregnancy as yet, and eculizumab. These are the three agents which are coming up on the horizon. I am sure in the next AICOG, we may be able to get more answers to this. One condition which I am repeating here, not repeating in this lecture, but always in all lectures, is a morbid fear which we practitioners have many a times when we see a subchorionic hemorrhage in subjects in whom we are treating with aspirin or aspirin heparin in early pregnancy. Please understand this. Latest results have shown that this is an expected event. There is no relation with the size of bleed as regards the outcome. So don't be afraid to stop. Don't stop your aspirin or aspirin heparin. If the fetus is thriving, no need to do anything. Don't stop measures. However, if the fetus is gone, then it is superfluous. I need not say that stop heparin. Explain the prognosis. Chances of miscarriage due to parent process, and that is a fight or a war between the destructive cytokines and the protective cytokines, can in itself destroy the conceptus. But that has nothing to do with SCH. Please. And this I was telling for many years, and as late as August 2022, we have got a good evidence to prove it. Some new associations have been found with recurrent pregnancy loss. And it has been found that midlife osteoarthritis or osteoarthrosis has an association with recurrent pregnancy loss. Asthma in later life has been found to be associated with recurrent pregnancy loss, and vitamin D deficiency and insufficiency are associated with recurrent miscarriage. These are associations, and all associations are not necessarily causations. Don't be emotional, be rational. Use your brains, not your hearts in this. Fall back upon data. No, at no cost should this pregnancy go. It is not in your hands. Don't try to play God. Don't try to play nature. Let science do its job. If you are scientific, you will get results. So be scientific, be rational. Not a single agent should come on your prescription pen about which you have not read. Don't be emotional. If you have this type of confidence, then of approach, then you will be so confident so as to laugh even without teeth at a dental cream promising you strong teeth, because you are rational. And then you are able to fly on the horizon of rationality and scientific treatment at the service of humanity and mankind.
बनूं उड़ती फिरूं मस्त गगन में, आज मैं आजाद हूँ दुनिया के चमन में। पंछी बनूं